Welcome, everyone. I am very excited to get started today. Despite years of progress in clinical reasoning education, diagnostic error remains one of the leading causes of patient harm. And generative AI is fundamentally changing how clinicians think through diagnoses and management. So today's session will explore how to ensure generative AI augments rather than undermines that critical thinking. We're so glad to have you here. Without further ado, I am excited to introduce our presenters. Dr. Verity Schaye is an associate professor of medicine at NYU Grossman School of Medicine, where she practices as a hospitalist at Bellevue Hospital and serves as assistant dean for education in clinical sciences. A nationally recognized leader in clinical reasoning education, she is a 2024-25 National Academy of Medicine Scholar in Diagnostic Excellence and has been at the forefront of integrating AI into clinical reasoning, teaching, and assessment. We're also joined today by Dr. Ben Moeller. He is Chief Content Officer at Sketchy, overseeing content development across Sketchy's core learning platform and DDX by Sketchy. A Columbia-trained physician, Dr. Moeller has spent over 6 years translating complex medical concepts into engaging, evidence-informed learning experiences, leading a multidisciplinary team of physicians, educators, and creatives dedicated to making medical education built for modern clinical practice. And with that, I will pass this out. But first, actually, the session details. So the session is being recorded, and we will be sending the recording out to all registrants within the next day or so. Please ask questions at any time using the Q&A, and we'll be sure to get to them at the end of the presentation. And the presentation should last around 45 minutes, and then the Q&A will allot about 15 minutes for that. So thank you. And with that, I will pass it off to Verity.
Wonderful. Thanks so much for the Sketchy team for having me in the introductions. Let me just get my slides up here. All right. As Hilly noted, I'm going to be for the next 30 minutes or so talking to you all about how to think about how we train this era of physicians, or kind of clinicians in general, not just physicians, because I know we have some people from different disciplines here, to be practicing clinicians in the era of AI. And so I'm really going to focus on how to prepare for the clinical environment, not as much on use of this in your sort of educational kind of day to day, because there's obviously so much you could talk about here, and only so little time today. So, why are we not advancing? My OneDrive is being finicky, and there we go. Just some disclosures. I'm going to be talking about a little bit this work, and again have the opportunity now to start working in consultation with Sketchy as well, which very excited for that upcoming partnership. So I always kind of start a little bit with laying the groundwork. I'm going to talk a little bit about why this matters and human reasoning and where we're going wrong now and what we know before the era of generative AI, because AI has been around for decades. Really, it's generative AI since 2022 and the launch of GPT that has really kind of then frame shifted this entirely. And then talk about, well, how do we layer AI into how we clinically practice, how do we prepare our learners for that clinical practice, and then hopefully inspire you all of, well, what are you going to do next to take this home to wherever you are, whatever institutions, wherever you are practicing. And I kind of say all this too, I know I frame it of how we prepare our trainees, but it's also how we prepare ourselves, right? Because we have to get up to speed as much, maybe even more so, because sometimes they're more technologically savvy than we are. So, faculty development being a huge key part of this, of course. So as I said, I'm just going to do a little bit of level setting, what we know about human reasoning, because it makes a lot of sense what works and what doesn't work when we layer AI into our clinical reasoning process, and what we need to think about, what are best practices, and how do we train folks to integrate AI into their clinical reasoning process. So first, just why we need to do better. And this is now actually almost a decade old, but things haven't gotten much better of the rates of diagnostic errors. And this is from the National Academy of Medicine, their landmark report. More people are familiar with like To Err is Human, which really revolutionized the patient safety movement. This is a follow-up seminal report of theirs shedding the light of the pervasiveness of diagnostic errors. And this is despite wonderful healthcare systems, great clinicians, right? Like, things go wrong and the impact this has on our patients. And this, of course, predates the era of generative AI. And they put forth several calls to action. I'm just going to highlight a few that are the more education focused. Obviously, we don't practice in a silo, we practice in a system, but this is not a systems-based talk. This is an education-based talk. So I'm going to highlight the more education focused of these and the things that we could do. So, to train healthcare professionals about the diagnostic process. Now it's training them how AI integrates into that diagnostic process. Ensuring health information technology support. Granted, this was before generative AI, so it was more talking about the EHR and other kind of predictive AI, but certainly applies to now with generative AI and all those other technologies. And then diagnostic performance feedback. I'm not going to get into that today, but that's a lot of also the focus of my work of like how we can use AI to enhance feedback that we're giving to people on assessment of clinical reasoning and diagnostic performance, but it's certainly kind of an important part of this. And just so we kind of all are saying the same thing, what do we mean by the diagnostic process? And really, like, this is both like diagnostic reasoning and management reasoning, which I'm not going to get into the weeds of the nuance between the two for today's discussion, but really a patient-centered approach. Patient engages with the system. We as clinicians gather information in different sorts of ways, come up with a working diagnosis and treatment plan, communicate to that patient, certainly an iterative process. Where do things go wrong? Overwhelming majority, there's a component of a faultiness in clinicians' thought process, right? Again, we're not practicing a silo. They're often multifactorial systems things at play, but often that there is a cognitive error and a fault in the clinician. And when I say clinician, again, physician, nurse practitioner, whoever the clinician might be on the team. So using that term broadly, intentionally. And so what do we know that works and doesn't work? Again, pre-generative AI, which is going to make sense of when I frame, I'm going to go through that, like segue in a second, to AI, bucket into these two kind of categories: strategies that promote knowledge organization and strategies that promote structure reflection and like working in teams. So like distributing thought, the group think, if you will. And so things that have been integrated into clinical reasoning curricula, things about teaching the concept of problem representation. How do you abstract out what are the core things about this patient, right? That this is, rather than this patient's coming with 2 days of something, an acute process. And then it helps you match to how diseases typically present. So the protocol representation of a disease process, illness scripts, or like for gout, someone coming with acute onset, monoarticular, large joint pain, matching that to the patient presentation. Management scripts is just then, well, how do we prototypically kind of diagnose and manage that? And then the systematic approach to a problem. So this is again, been infused into clinical reasoning curricula. This is, things, and you'll hear more about the Sketchy platform, could really be really helpful of like building the reps of this and building into your clinical reasoning curriculum overall. And so, in real clinical practice, generative AI is probably going to come into play a little bit more in these distributed cognition, structured reflection of like diagnostic timeout. But there's plenty of literature just pausing and like thinking about my thinking does not help. So doing that in a structured way, like what did I miss here? What other diagnoses should I think about? And again, generative AI can be helpful there and I'll talk about this more. It has infinite medical knowledge base. We do not, right? To help promote that structured reflection, right? And then working in diagnostic teams, having alternative thoughts, perspectives and points of view. And generative AI can play infinite roles in different perspectives and points of view. So again, I'll exemplify that a little bit more. So I think it's important to understand this. And like when we say, well, this doesn't work, well, this is why. We kind of already knew that from the plain old human reasoning literature, / this does work. And that makes sense based on what we know from the human reasoning literature. And then I'd be remiss not to talk about documentation. I'm going to talk a little bit about ambient AI because that drastically changes how we practice clinically and is so integrally intertwined into how we think and reason. And I'm sure people have heard the phrase like writing is thinking, right? And so it's something we're going to have to think about. And I'll talk more about ambient AI in just a few slides, but just kind of recognizing the fact that historically documentation served a really important role for clinicians, both to develop, so far earlier learners, honestly, when I'm a hospitalist, when I'm attesting my notes, that's when I do my real deep thinking. When I'm struggling with a case is when then I'm writing my note for that day. And that's also how we assess learners too. So I know I'm not going to talk really about assessment today, but that's also something to think about when we get into assessment of reasoning, because that's the best artifact retrospectively we have kind of right now, which again, Ambient's probably going to be a game changer there as well. So now AI, and I'm going to do kind of just a brief survey of some of the literature again, specifically within, clinical reasoning, of course, because obviously there's other clinical skills at play here as well. So I'm not going to really talk about like communication, because that certainly is another part of the process, but really more about like differential and management generation when I'm talking about clinical reasoning here, and kind of zoom into that part of the clinical reasoning process. Old news, study after study, and again, this literature is so fast, so these slides will be outdated tomorrow with like 5 new articles that have come out. But it's a very fast pace. But study after study, large language models, whatever the model might be, right? And some of these are with GPT-4, now older models, right? That we've now even evolved past, so they're getting even better. Under controlled circumstances, do better than humans, right? We don't practice in simulated, clean data set environments, right? We practice in the noisy complexity of the clinical environment. So all these studies are like a CPC type case, like an aliquot of curated information fed into the LLM. The LLM does better than a human with the same aliquot of information, right? Clinical practice doesn't work that way. We're pulled in 5 different directions. The EHR is messy, getting the right data, right? So it doesn't necessarily translate, well, AI is better, and we don't need to make diagnosis anymore as a human in the clinical environment, right? Because it just doesn't fully translate like that. And that being said, like LLM reasoning, as I mentioned, it's only becoming more complex and advanced. And to kind of highlight the concept of like how it could be used, and I'm going to show a few studies then how it's actually used as sort of like a diagnostic, whether it's a team member or tool, again, one could debate what you call it, playing different roles, playing different perspectives and point of views. And I think this study in particular highlights it really well. And this is a preprint where they essentially had AI play several different roles, and I'll zoom on that a little bit further. So playing like a hypothesis generator, a test chooser, someone that challenges, value-based medicine, so like a stewardship arm, and then an overall checklist. Like that, again, sometimes it's wonderful. You can go ask your 5 colleagues sitting in the call room. Sometimes they're not always there, right? And so kind of to bounce ideas off of and get some of that sanity check or a different perspective or a different point of view, you still have the final say of like, okay, what's a diagnosis for this patient and what are we gonna do about it? But right, to kind of get those different viewpoints. And this is just kind of some of the outcomes of that. And again, this was also simulated cases, not in the real clinical environment, and mapping diagnostic accuracy over cost, so kind of a value-based perspective to this. And there was a certain point, cost didn't get you better accuracy, which we know from value-based medicine in general is not a shocking concept. Down here, though, is when they had humans use, again, they use, as you see, like different potential different AI, generative AI tools. You see them kind of listed over there. In this, they were like, hey, humans, go use AI, right? So there was not any structure. That makes total sense from what we know from the human reasoning literature. Hey, human, just go think about your thinking. Hey, that doesn't make you a better diagnostician, right? So using these tools without instruction, how to prompt, how to think about a structured timeout in terms of the clinical reasoning specifically did not yield better performance. And we see that in several other of the earlier studies of AI plus human reasoning. And this is just kind of a sampling here that hitting home that same concept of being like, hey, human, go use AI in your diagnostic, and these are all, again, simulated cases as well still, did not yield better performance. But none of these had this is what you should prompt, this is how you should use it, this is how you should do it in your process. Makes total sense based on what we know from the clinical reasoning structured reflection literature prior to LLMs. There have been, though, right, a few studies that are showing a lot of promise of in a structured way with, prompts created by clinical reasoning experts who know intimately the structured reflection literature, how to build your prompting that do show yields, promising outcomes of the human plus AI. And why this is important, as I kind of started, human alone is not good enough in many cases, right? Again, 10 to 15% diagnostic error rate in hospitalization cases. I know I didn't quote some of the numbers at the beginning, but like we want that number down, right? And we've tried all sorts of things over the last decade that have not worked. And so this, and I guess maybe one of my disclosures, which is probably obvious from my talking, is I'm an optimist when it comes to this stuff and the promise, with ethic responsibility, right? And of course, we'll talk about some of the validation and some of the things that in terms of when learners integrate in this process, and I'll talk about pivot to that in just a second after just going one or two over a few more studies here. So this is the first of the studies I'll just kind of highlight of like what I would call structured integration of AI plus clinician as a diagnostic team member or kind of as a diagnostic tool in the diagnostic process in simulated cases. So in this case, like the study team members created the prompt, right? So then there, again, you see kind of some of the co-authors here who have expertise both in AI and clinical reasoning. They created the prompt. So it wasn't the frontline clinicians that they enrolled creating the prompts here, right? Ultimately, again, this was simulated cases of, they had 3 different arms. They had, they just did AI alone, so what AI put out. And then they had 2 different AI plus clinician arms. They had an AI's first opinion, where AI gave its output to the human, and then the human integrated that into their final diagnosis. And you see kind of some examples on the figure from the article on the right there. And then they had an AI second opinion arm. In that case, though, the human gave AI what it was thinking, and then AI gave its output. So the second bullet point there, the big caveat is, again, AI is sycophantic. It wants to like agree and comply with humans have to say. So the AI output was significantly influenced by the human there. So that's a big caveat takeaway to then the outcomes in the first bullet point, that AI's first opinion outperformed AI's second opinion. But AI is performing differently in that second opinion. So it's not necessarily AI's first opinion is better than AI as second opinion. And I'm going to talk about that more as we like, well, how do we think about this with our early learners, right? And maybe that works for AI to give output and an experienced clinician be like, okay, let me integrate that into my thinking. But an early learner, they need to commit to their thinking first and then have AI output and then integrate it, right? So they can help with their skill development. So that's something very much we have to think about here. And there's just not as much a body of literature on that yet. Certainly it's a very evolving field. And this was the first study, at least like the AI plus clinician performed equivalently to AI alone and outperformed, compared to human alone. So like AI plus human was better than human alone, and at least equivalent in this case to AI alone. And I don't think we're ready to for AI to be autonomous yet in the clinical environment in this task. That's kind of an important thing. It upskilled the human. We're not ready to be like, hey, AI, just go do this without human oversight. So how do we do this right? And the combination. Also, not necessarily surprisingly, which we also see this in the plain old structured reflection literature, that the most consistent gains are seen in the hardest cases, or in this case, the lowest performing cases. And it potentially can make you worse or second guess yourself or overthink things. So that's just a caveat here. And we know that from the structured reflection literature as well, that it doesn't necessarily help in every case. So should we be using this on every case? What cases should we be using it on? These are some outstanding questions that we don't have all the answers to. Another study, I'll just go over this one quickly, of just kind of showing, this is also just using AI in a little bit of a different part of the process. They use 3 different arms here of Amy, which is a Google based AI tool, and then information gathering from again, simulated scenario and a simulated patient, so a standardized patient. And so they had, again, electronically, not in person, either Amy gathering the information from the patient, a more junior primary care doctor, so within a few years of graduation, so early early faculty member, or a PA or NP gather the information from the patient, generate output in the form of documentation, and then they had a senior PCP review those outputs. And they ultimately found that both from quality reviews of the notes and also perceptions of the senior PCP, that the combo of Amy plus senior PCP was the most favorable, the most efficient, and the most accurate as compared to those 2 different arms. So again, another way, AI could be potentially used still with human oversight of kind of layered into that process. And then the last study I'll talk about before then, I'm like, okay, well, how do we teach our learners how to do this and integrate this into our curriculum? This is the only real-world study, big-scale real-world study that exists for now. And so this was done in Nairobi, and they randomize clinics, either primary care or urgent care clinics, either to AI arm or just standard practice. So there wasn't an AI alone, arm in this. And they essentially had running in the background, and you see a figure example of this, of like AI output at different parts of the clinical reasoning process that triggered during documentation of the clinician. So after the history was documented, after diagnostic testing plans were documented, diagnosis and management. And then they kind of trained in, again, lots of prompt development. They share all their prompts in the article itself. And if there was like a red flag of like, there's a big discordance here, so it wouldn't be triggering on every single case to not cause like cognitive overload. So this was like a red flag. There was a green, yellow, red flag in the background. And so the red flags would show face forward to the clinician. In this case, it was gastroenteritis. The clinician recommended metronidazole. The AI response was like, are you sure about that? Is metronidazole really indicated here? The clinician ultimately decided not to give metronidazole. And after kind of reviewing that and making that, synthesizing that into their final decision making. And in this case, AI plus clinician outperformed human alone in all steps of the process. Again, they didn't have an AI alone arm. And also interestingly, there was a reduction in AI interventions over time. So the takeaway, the interpretation from that is clinicians learned over time. After they got AI interventions, they were learning, and this is it's a way of kind of giving constant iterative feedback to their diagnostic performance in a way. So I think, again, we have a growing body of literature of like the promise of human plus AI, and it's only going to get better. So we have to think about, well, how do we train our our rising, trainees, our medical students, our residents for this future. And actually, before I do that, I forgot I have a slide on ambient AI. Just talk about that first before I make that segue, because this again, it's so intertwined and so much power here, right? And that's going to change how we teach about clinical reasoning and how we assess clinical reasoning. And AI can be used multiple different ways in documentation, certainly just helping extract information from the chart, summarizing, so that part, the information gathering part of the clinical reasoning process. And then study after study, which is very important about satisfaction with ambient AI. Most of this is with faculty. There's not really much with trainees about wellness, enhancing wellness, decreasing burnout, which are very important metrics. Not so much just starting to come out. Well, how does that impact care quality, right? Documentation quality, and then ultimately care quality. And then the big question with trainees is like, well, when do they introduce this in their skill development? Because you need to be able to like critically appraise output in order to kind of use this in their practice. So that becomes a big question of like, when do we allow or should we allow medical students to use this? Is it not until they're a resident that they get to use this? But if they're going to graduate into the practice and this is what's being used, we have to train them how to use this, right? So bottom line, like, this is the new clinical reasoning process. AI is part of this process. And so we have to train future workforce and uptrain ourselves to do this in our own practice and to supervise these individuals to be prepared for this. And so what do we do when we're thinking about curriculum and preparing them to really, again, when I talk curriculum, I'm going to focus on how we prepare them as clinicians to use this in their clinical care, because obviously there's so many ways to integrate this in curriculum, and both just for like using for iterative reps and of practice and development as well. So I'm not going to be touching on that, but you'll hear a little bit more from Ben about the Sketchy platform at the end about that. So as I've already kind of alluded to, the elephant in the room is, right, like the big concerns when we're talking about trainees and certainly full-fledged faculty, and really more for earlier trainees, like, will they never learn this skill, right? Will they never learn how to document if we give them ambient AI just from the beginning? Will they not learn how to prioritize the differential if they're just dependent on AI? Deskilling, so, if they've already learned this skill, will it make them skill decay over time? So these are all very real things that we have to think about. And again, still, as you'll see the last bullet point, we need more research here. So still a very moving target, but what we know today, and as I've already kind of shown some of the argument, and we're only going to get more data if there's human plus AI leads to upskilling, right? The sum of its parts is better than human alone. We have to make sure our learners are prepared for this, right? Like, that's what our patients need, right? Granted, maybe there's some things that AI can do without our oversight, right? Like, I don't think clinical reasoning is one of those yet, like, but there are something, prior auth letters, AI can have it, right? Like, or be autonomous. But again, what are like human plus AI skills, right? And I think clinical reasoning is one of those combined skills. We don't yet fully know, though, when we introduce it, right? Like, as I already kind of said, like ambient AI, should we, as you, and some potential strategies here, you need to have demonstrated a certain level of competence in your documentation and your differential diagnosis prioritization before you can integrate AI into your practice. That requires obviously a robust assessment program to set up and do right, and could be challenging. So a simpler way of doing that is at a certain stage of training. So like PGY 1, 6 months into their training, or acting interns can, but clerkship students can't, right? At the same time, though, like there's certain things we can't regulate. Like, and I'll talk about, everyone's using open evidence in the clinical practice, and I'll talk about that a little bit more about different tools. It's hard to say like you can't use open evidence when you're on rounds, right? You can be like, I'm not going to give you an ambient technology license, right? So you also have to recognize like there's some things you can have some policies and guidelines in place, but like they're still going to use. That's okay. We just need to say this is how you use it correctly, right? And so when thinking about, and this is just some examples of some of the curriculum, and I'm going to show you an example of some of this in a few slides as well. And this is certainly very much moving target, and we're still very much building our curriculum here at NYU. But there's nothing that beats getting hands-on. I'm going to show you an example, the clinical reasoning use case from our kind of hands-on session that I myself and along with Dr. Triola do with the medical students. And I also actually do something similar with our internal medicine residents, being a hospitalist with that residency group. And just some of the things of like what you need to cover, and this is from Dr. Triola, Dr. Rodman, both leaders in the field. You need to think about, well, what competencies do I need to cover? And so certainly part of that is application to clinical care, right? Which is what I'm focusing on here. But we need to, when you're kind of building out curriculum, you need to think about, ethics and regulation, some fundamental knowledge. Obviously can't cover all of this in this session today, but when you're, thinking about building out curriculum, of preparing trainees for this future, you have to kind of think about what are the range of competencies, and obviously application to clinical care being one of a wider range of things we need to prepare them for. And as I already said, like you need to have guidelines, recognizing some of these are enforceable, some of these are not, and so kind of preparing for safe use and recognizing what is possible. And most of your institutions on the clinical side theoretically have already policy and procedures. So whatever you come up with on the education side obviously needs to match what your clinical mission is saying. And so this is just an example of and which we're in the midst of revising now, because this again been such a fast-moving field. So some of this needs to be updated. But this is an example of some of our education guidelines we have for our students and residents. And a lot of this also is about data privacy, right? And it's going to depend on the institution, like what internal instances you have, right? So if you're using patient data, you have to be you cannot put patient protected information into public tools. So into the public ChatGPT or into public Claude or, whatever company. And so it's going to depend on your institution, what you have within your firewalls. Like open evidence is not HIPAA compliant, right? So you could be like, I have a patient with cirrhosis, like XYZ, but you can't give further patient identifiers, right? So that's something that's really important to talk about when your trainees are using this in clinical care. And if it's simulated cases, sure, can go in whatever platform. And then you also, again, I'm not going to delve as much into assessment, but like when they can and can't use it, what assessments you want to say, you can't use it in this because I want to assess your human alone, thinking versus this assessment, I want to assess how you use AI. So that's another thing that has to be in policy and procedures as well. So I'm just going to show you kind of a brief overview of like the platform that we use to prepare in our curriculum to prepare our trainees to use this in clinical care. So this is not to use it as like virtual patient reps of and something more kind of like the Sketchy platform, which uses as a slightly different use case. And this is a publicly available resource, so you can kind of use this, take it in your curriculum if you'd like. And the platform itself was created by Dr. Triola. I did a lot of the clinical use cases here, and I'm going to show you, of course, the clinical reasoning use case. And also on here, too, I'll show you before I show you that, is like a whole bunch of resources of how to stay up to date with AI. I know I'm not getting in the weeds of some of the prompting practices, but like, how to prompt, is really essential. Different people to follow. or newsletters to stay up to date on the most recent articles and things that are going on in this field, because it could be hard to stay up to date here. And so this is an example of the clinical reasoning use case, and this is really framed for an earlier learner. So this might look slightly differently for a later stage learner, but to that point of like the AI's first, to go back to that concept, AI's first opinion versus second opinion, and kind of the concerns about deskilling and never skilling. And this is kind of like the concrete exemplifying of like, well, how we introduce this to our learners to factor in all those things. And so we have, these are simulated cases, so they can be used on any public generative AI, LLM tool. Have the learner commit to their human-owned differential diagnosis first. So be like, use your human brain first, both differential and management. And then, as I mentioned too, of like, well, prompts that are embedded in the structured reflection literature, rather than just being like, oh, we still want them to play around those prompting, but like we have prompts to kind of get them started that are grounded in the structured reflection literature using this framing, which is again grounded in the structured reflection literature. Just kind of standard things. What are things supporting, opposing each diagnosis? What would you expect? But it's not present, kind of what are the next steps? And so this is all grounded in clinical reasoning theory, and as are the prompts that we've, created for them. And so you have on the right side, the case prompts to get started, have them then use AI, fill in, does this change your diagnosis and management? Critically appraise that AI output does not necessarily mean it's right? That's a very essential part. And then have them self-reflect. How did this change your process? How will you use this moving forward in the clinical environment? So we have them do this in a safe space in the classroom, and to be like, these are some of the best practices for you to go forth and use in your clinical care day to day. And so we do this with the clerkship students once they have a little bit of clinical experience under their belt, and I do a version of this a little bit more, a level up for the internal medicine interns as well, to level set, because they're all coming from different med schools. We don't know what curriculum they got, to be like, these are the best practices. And then we talk about, as I talked about, like, well, what are the different tools out there, and getting to some of that, which tool you use, and the data privacy piece, what patient information you can put in where, and kind of putting in these three buckets, update, launch expert AI sometime last year. I think most people are familiar with open evidence, and like everyone's using this. And then there's just the general LLMs. And some of this, again, for us, we have an internal hosted HIPAA compliant server that has GPT and Claude and Gemini on it. And so make it clear, you could use that because that's HIPAA compliant for us. Like for you, you'll have to find, for everyone on this call, like, what does your institution have? And that depends on what you have within HIPAA compliant firewalls of what you can use for what, right? And so that's a big important thing to talk about, of data privacy here, and what information you're putting in what tools, and the evidence base for these tools. UpToDate Expert AI has the best evidence base. I think probably most of you on the call use UpToDate day-to-day in your clinical care, right? We trust that source. It's been vetted. UpToDate Expert AI is just pulling from that data source, right? Already very vetted. It's a little bit, I don't have an investment in any of these of these platforms, or so I have no disclosures to make around any of them. So these are just my personal opinions. It's a little bit of a clunky interface, right? Like and I think they're trying to iterate on it. Open evidence, wonderful interface. What it's pulling from, again, you have to question a little bit. And so again, it's really important to reinforce, not to say you can't use this, you really got to validate that output. And then similarly, like the LLMs, there's going to be variation of accuracy, what data it's trained on, what it's pulled from, because it's just pulled from the general internet, right? And not necessarily just medical literature. One of the benefits of the general LLMs, though, is there's opportunities for direct integration within the EHR, and that's going to depend, obviously, on your institution, what you have. Like we've got discharge summary, or helpful generation, documentation, summarization, that, again, really, that have, for a lot of people in our clinical mission here, have like done a lot of work in the validating before it goes live, and the clinical environment. So these are all important things to talk about, what tools you're using. And then lastly, and I think this is the wrap up here, is, well, how to talk about this in the clinical environment. So as frontline educators, working with the learners in the clinics, on the wards, faculty development, what framework, what language we do to talk about that everyone's reinforcing all those things, right? We could teach all we want to teach in the classroom. As we know, there's all the hidden curriculum in the clinical environment, what's being reinforced. And so this is a really nice framework published by Raja Ali Abdul-Noor called the Deft AI framework. Those of you who are deep in the weeds of education probably are familiar with like the 1-minute preceptor or the micro skills. And it's a similar framing to that, but I'll take you through this step by step. And essentially reemphasizes a lot of things I just said and gives frontline clinicians the language of how you supervise trainees with this, and also to use metacognitively on your own process as well to develop yourself. And so it's really about probing and asking questions like, what AI did you use to, in this clinical case? How did you use it? What prompts did you enter? Obviously getting the trainee to, and these are some example answers from the trainee to the supervising faculty. Evidence. How did you validate that output, right? How are you sure, again, that was accurate and safe, right? Would not be too excited about a learner telling me about social media posts being their source of truth here, right? And again, so that leads to an opportunity for feedback and metacognition to get them first, be like, how could you evaluate your own use? How can you improve? So some of that metacognition, and then teaching them general principles, right? And to teach them general principles of, again, this is what open evidence is good for, this is what up-to-date expert AI is good for, this is, you should commit to your human thinking first, validate the output, some of the things that I already kind of talked about. And certainly, obviously, everyone on here, I'm sure, has other pearls, kind of that just general teaching points. And this is kind of a continuation of that, continued way to kind of continue to improve. So it kind of gives the language in the clinical environment, day to day, as you're precepting a case, as you're talking on ward rounds about a case, in the operating room, how do we kind of generate language around this? So just to wrap up of kind of what I've taken you all through of like the moral imperative here of like, we're not doing as well as we like as a healthcare system overall at large in clinical reasoning and diagnosis. And this has a significant impact on our patients. And despite decades of work on this, we have not moved the dial. And AI plus human reasoning really holds promise here to improve patient outcomes, and that will really help us in teach clinical reasoning. We have to prepare our learners for use of AI in their clinical reasoning. They're going to be using it whether we like it or not, so we got to prepare them to do it right, how to do it, and what are the limitations. And also I'd say like we need to be part of the teams at the table conducting the research, how this gets implemented to help answer some of those unanswered questions. When do you implement this? The concerns of those that deskilling and never skilling. And again, I'm an optimist and I think it's gonna help us do our jobs. There's so many obviously other things as educators this could be used for, of course, was out of the scope of today's discussion, but to really help us do our jobs more broadly as clinicians and educators, and really allowed us to innovate and do a lot of really cool stuff. And so with that, appreciate everyone's time. And I think I'm handing over to Ben next.
Yes, and thank you so much, Dr. Schaye. And just as a reminder for anyone that has questions, please add those into the Q&A section, and we will get to them at the end of the presentation. And with that, I will hand it off to Dr. Ben Muller.
Awesome. Yeah, thanks, Verity, for the talk. That was an awesome sort of synopsis of all these challenges that everybody is wrestling with in different ways right now. And certainly something that we've been thinking a lot about for the past couple of years. And so, yeah, Hillary, if you want to go to the next slide here. We sort of have our little blurb here. I think the sort of two important parts of that are clinician built and AI powered. And so everything, Verity talked about the way that UpToDate is sort of underpinned by all of this expert written resourcing that you've sort of come to trust over the past decades. The idea is the same here. Every case that we write is underpinned by something touched by a practicing clinician. But then we use AI to enhance that and sort of power it up in ways that we'll review quickly. I'll skip the rest of this here, but just want to mention the awesome partners that we have worked with across the country who are implementing this in all kinds of interesting and creative ways across their cohorts. So three sort of threads to pull out of your talk that I want to sort of connect to DDX. Well, one's maybe a cheat or a preview, but the first is the safe AI training. And I think we mean safe in two ways. One is you sort of alluded to the idea that learners need ways to practice early on. And so certainly a virtual sim is an easy way to get students reps and practice without exposing them to patients and thereby to patient harm. But I think the other way that we mean safe here is in that kind of never skilling or de-skilling concern, where the whole purpose of this platform is to put the burden, honestly, of clinical reasoning on the learner and to have them sit in that seat in a way that they really don't have an opportunity to do, especially early in their training, until they sort of gain some more responsibility. And then, of course, on the AI side, teaching them how to use these tools is certainly an interest of ours. I'll reiterate my pitch from last time that if you're an educator and you're thinking about how you might start teaching students to use open evidence or have that deft conversation that Verity mentioned, if you're concerned about that, we'd love to hear from you and sort of what the hurdles and the sticking points are for you. The second idea here is scaled exposure, and I mentioned this a little bit already, and Verity, you talked again about students just need reps or ways to get this kind of practice outside of the clinical environment. I think especially with the pressure of these tools, whether it's the ambient scribes or the open evidences of the world kind of impinging earlier and earlier in clinical training, there's even more burden to get students that clinical practice and clinical exposure as early as possible, which we already know is a challenge. And so for us, DDX is another way to get them that exposure and that practice before they sort of run into that hurdle of never skilling. And then the last thing here, and you didn't talk about assessment, though I know you have tons and tons to say about it. And we'd love to hear from you on that at some point. But we also care a lot about assessment, and I'll talk a little bit, I'll show a demo quickly of how we think about assessment. And again, where AI can help sort of support student learning rather than replace their own leveling up. So I'll jump into a demo really quickly here. And I know I want to make sure we have enough time for questions at the end, but just to highlight a few things. So the first is the library. And, again, we have a whole pile of cases that students can practice on, over 200 at this point. And just to reiterate, what I think hopefully is obvious, we don't think this is a replacement for real human interaction, whether that's with a standardized patient or sort of actual practice on the wards. This is meant to support that process, but there's nothing like being in the room and, getting a little tachycardic to really sort of make the point to a student. So quickly, we won't run through this whole case, but I just want to highlight a few features here. And the first is, again, on that idea of building clinical reasoning, our cases start very much with that in mind. So you don't know that much about this patient. All you know is he's got a cough and his initial vitals, but already we're trying to build that habit of mind in students of formulated differential. Come up with something that you can then start probing as you ask the patient questions, as you do the exam, as you think about what studies you want to work up. And so I'll just fill in something here. Let's see, maybe he has COPD. And then you'll see that as we proceed through the case, that list lives on with the student. And we encourage them to do the same process that you all as clinicians do implicitly and update that differential diagnosis, move things around, add or remove diagnoses from your list. And we sort of make that explicit for the student. So then they have the opportunity to talk to the patient. And, I assume at least most of you have used an AI tool at this point. We're able to have this naturalistic conversation with the patient. Again, everything that the patient is sort of sharing with you is built upon a clinician written structure here. So I'm going to be a little bit rude to Alfred, but we'll just jump right into that to illustrate one thing. So, I put COPD on my differential there, and then I want to find out about that. And so throughout the platform, we have layers of scaffolding that we can kind of strip away for more advanced learners or keep in for earlier learners. And so here's one example of what we call a key finding, sort of a signpost to let a learner know they're on the right track, that they're proceeding down the right path as they go. Again, for a more advanced learner, maybe for a resident or something like that, we can strip out some of that scaffolding or the hints that we offer to students. And so up top here, you can see sort of the steps of the case that students would proceed through. What we think of as kind of the full spectrum of a clinical case. And I'm going to jump just ahead here a little bit to look at the results and highlight that we can put in all kinds of media and imaging. And, I think especially for an earlier learner, if you hear about a person coming in with a cough, maybe IPF isn't at the top of your list, or maybe it's not even on your list. But hopefully as you start to get some of these results back and think about the case a little bit more, that moves up your list, and we can, again, sort of track that on the right side here. And then, again, with the power of these tools, we can probe them on their thinking. So great, we just showed you some PFT results. Let's just sit down and talk about that. And I assume that for many of you who work with students or trainees, this is a conversation you might really have with them, is sit down, look at the labs, and kind of ask them some questions about it. And so we want to mimic that same kind of clinical reasoning training throughout the platform. So as you can see, we proceed through the rest of the case with a little bit of management of this patient, and then we talk about his course of care, leave the student with some learning points, and at the end of the case, we offer them some feedback. And so obviously we're not going to get any feedback on this case, but I'll jump over to one that I've done already for a different case. And so you can see the kind of assessment and evaluation that we provide students here, as well as sort of supportive feedback. And so for each kind of clinical reasoning component of the case, we offer them some strengths and some weaknesses, and then provide an overall score. And then for you as educators, you can come back in and review for your whole cohort, how are people doing across that spectrum of clinical reasoning thinking. So I'm going to stop there so we have enough time for questions. And I know Hillary's going to say this as well, but I know this is a brief demo. You can try this on your own for free right now, and Hillary will have some more details on that.
Yes, thank you, Ben. And with that, we have a QR code here. If you would like to try it out yourself, you can scan it and sign up for our free trial, explore up to 6 cases, and the reporting tools for free. And this will also be on the slide for questions too. And I do know that there are a lot of folks that are asking about the slides and the recording. We will share the recording for sure, and then I will confirm whether we will be sharing the slides following this presentation. So thank you so much for your interest. Okay. And then this is a second part in a 3-part series where we're focusing on AI as it has to relate for clinical reasoning. Our next one is diving deeper beyond diagnosis, teaching patient management in the age of AI. We'll be joined by Dr. Andrew Parsons, and we'll really be focusing on the patient management aspect and how combining human and AI together. So really looking forward to that. I will be sending a link to the registration page when I follow up with the recording of this webinar as well. So please keep an eye out for that too. And we hope you can join us. And with that, we will get to questions. So please submit your questions in the Q&A section and we will try to get to them. And you can also upvote questions too. So if you see one that is already there, please upvote so we can be sure to prioritize. And so with that, our first question is, how would you simplify? At what stage would you start them on using AI as a collaborator in this process to prevent unskilling?
Yeah, and I think there's the practical in the room of like what we control and what we can't and what they're going to do anyway. And I saw a question later on too about like ambient versus LLM technology. So it kind of also relates to that of like, once they hit the clinical environment, they're going to be exposed to all the residents and faculty using these tools. And so we can't like not talk about it at all because then we're not preparing them right to the clinical environment. They're going to see this model and be like, well, why wasn't I taught this way? Like you're teaching me something that feels so disconnected from how people clinically practice. And that's a very like real reality, right? And like we can have guidelines and policies and certainly have obviously institutional kind of policies about HIPAA compliance of what you can and cannot use. But certainly you can always use sort of like, I guess, give example before, like generally this patient with cirrhosis, like XYZ without, patient identifiers. So they're going to be seeing that the second they click to the clinical environment. And so we have to at least talk about it before they get there. We intentionally, as I mentioned, the session we do with them, and we've kind of played around like every year of like, when's too soon, when's the right time to really kind of go over the right skills. And intentionally we do it after they have a quarter of their clerkships, like the first quarter of the year. So it's more contextualized for them. We talk about it beforehand. We've got broader talks of like AI and what you're going to see in the clinical environment, but then we don't get to the nitty gritty of like kind of how to use this, but we're also thinking about moving it earlier. And this is certainly a learning, process for us at NYU. But the key part, which I know was, again, is not part of my talk, was like the assessment side. And, if we introduce it early, we also have to think about our assessment programs and prevent the never skilling or the de-skilling, and think about our assessment programs holistically of like needing to maintain assessment of human alone skill, and then assessing human plus AI skill in clinical reasoning, whatever the skill might be where you're combining AI. And that's a key part of this as well, not just when you teach it, but how you're assessing it to make sure that we're combating the never skilling, particularly for the early learners, or like the de-skilling once they've learned that skill. Ambient is a little bit of a different conversation because we can control, right? Like, I think this is similar across institutions, like licenses are at the provider level. It's up to the institution whether they pay for a license for how many people, right? So we can very much regulate that. Like, you can't use that in your clinical practice, or you can. And so that we do have more control over when that gets introduced, which is very different than just like the general LLM tools. They're going to use it, right? They're going to use it the second they hit the clinical environment or preclinical. So we have to talk about it and we have to teach them how to do it right, and also assess them to make sure they're having the skill development they need.
Great. And then what would be your suggestion on integrating this metacognitive discussions around the use and commenting on that when working with large classes of pre-doctoral students instead of one-on-one or small group learning environment discussions?
Sure. Yeah. I mean, I think there's, and I know Amor talked about, certainly the in clinical care, but I think some of the same principles very much apply whatever the use case is of, when you're synergizing whatever human plus AI, whatever the skill might be, research or other clinical skills and some of that it kind of that gets to also some of the overall AI competencies that I put up. I know, again, obviously I've zoomed in on like how you prepare them for the clinical environment, but about critical appraisal and some of the kind of the ethics around this. And so some of those general principles still apply, if you're using this for other types of skills of the integration of the human plus AI, validating the AI output, integrate, you still having the final human oversight of like what the decision is or what, kind of how you're kind of putting those things together. So those general principles apply to other skills and are not unique to clinical reasoning.
Great. And I believe you already addressed this, but anything to add around what is the basic guideline to give students?
I don't know if that means like general practice of use, policy, and procedure. So I guess I'll answer it both ways unless we've got a clarification. But again, I think it's sort of kind of just reemphasizing what I said of like that there are certain things we can't control that they're going to do, and we're doing them a disservice by not teaching it and talking about it early. I sometimes equate it to like sex education, like we got to talk about it. They're going to be doing it. Like, we have to talk about it. We have to talk about safe sex and using protection and, kind of all these things. Like, and same things with like AI. Like, they're going to be using it. There's only so many rules we can put on it. Like, we have to talk about it, teach about it, how to do it right, and not wait till it's too late and then it's unsafe for a patient, right? Not teaching and talking about it is not going to prevent them from doing it. It's going to facilitate them doing it wrong.
Great, thank you. Okay, what does the case library look like for this product? How many cases? What's the depth and breadth of the topic organ system case library? Also acute, chronic, preventative, etc.
Yeah, great question. So, the short answer to this is yes. We have a couple hundred cases, a little over 200 now. Sort of across organ systems, across rotations or specialties for medical students and NP and PA students as well, and for GME with more of a focus there on emergency family medicine and internal medicine. Sort of the spectrum of acute, chronic, preventative. And then, didn't touch on this as much because our focus here is on clinical reasoning, but we also have communications cases and sort of skills-based cases, how to interpret an EKG or read a chest X-ray or things like that sort of don't fall under the large umbrella of clinical reasoning, but are still obviously very important skills for students to develop.
Great, thank you. Okay, and then what might be institutional strategies to engage our clinical faculty in the use of this technology to help standardize an approach to our students' use of AI in clinical work?
Yeah, no, it's a great question. And it's a kind of, mentions like faculty development is so key. So kind of like everything kind of I went through also could be used for faculty development. And honestly, in many ways, I mean, well, yes, we're more clinical experts than our trainees. They're often more technological experts than us. And so we do tons of faculty, like some of the same sessions, obviously we tweak it and tailor it to the right level. But of faculty development around this, and certainly then having stakeholders within departments, that will help kind of on the ground within their faculty groups. Because again, we could teach the learners so we're blue in the face in the curriculum in the med school or in the standardized curriculum in the residency program in the classroom, but if they don't get it reinforced in the clinical environment, they're going to go awry or do it wrong or see it role modeled correctly. So it's like a full thickness approach here, and faculty development is so key, and getting your partners on the faculty side, the right stakeholders to kind of do these similar things with faculty is so essential for success.
Thank you for that. Okay, and what are your thoughts on the System 3 thinking of cognitive surrender in clinical reasoning domain?
Yeah, I mean, there is like a lot of the, sort of like if you lose the productive struggle, right? Like, and how that impacts skill development in general, whether it be encapsulating medical knowledge. Obviously, clinical reasoning, medical knowledge is such an essential cornerstone for clinical reasoning, right? You need to have the knowledge base to kind of to pull from. And that's why it's so important of how we think about teaching this. And like, again, some of the strategies I've talked about, we can't necessarily enforce this, but at least to talk about best practices of like commit to your own thinking first. Like we can't fully enforce that. What we can enforce though is in our assessments, this assessment, I'm not letting you use AI. And that learner takes that assessment, they're like, okay, like I need to be worried here. And we need to then, think about how, again, our global curriculum remediation for this individual learner. And I think that's where that comes into so much play here, and tied into the, the deskilling and the never skilling if they're offloading too much and they don't develop the infrastructure that they need to integrate AI into their human process, their human reasoning process.
Mm-hmm. Makes sense. Okay, I think this is for Ben. Do you have client institutions who assign certain cases during their core clerkships and assess their performance on this platform as part of their demonstration of acquired competencies?
Yeah, absolutely. And I think that's one of the kind of core use cases for DDX right now is sort of in partnership with the clerkships, as they're seeing real patients in the wards, get that practice, see things that they might not get exposed to, get practice on things that they'll see very regularly. And then we use or faculty use the feedback and the evaluation tools that we have in the platform for their students as well.
Okay, thank you. And then what AI prompts might you recommend for struggling early learner, prompts to help them prioritize information as they are learning, e.g., not every piece of information that they are memorizing is equal in weight?
Do you want me to take that, or Ben?
That's an interesting question. Yeah, I don't know if you have. I think this is asking about how to use AI sort of in I don't know, a meta studying way to help them organize the vast corpus of knowledge. Is that how you're reading it?
Yeah, it seems to me it's more about like development of problem representation. So I think it gets into like the use and things like the Sketchy platform can help, which I know is not as much as what I've like talked about, of like development of problem representations and like the infinite reps that virtual platforms like Sketchy can provide, and like and then help compare of like, feeding that data and, having the learner be like, come up their problem representation, feeding that data into the LLM, or again the output in the assessment from Sketchy of like, well, this is a problem representation, the data that I would have emphasized, here. And I think it's some of that, the infinite reps that this allows to help with remediation, to kind of, to show that.
Okay, and with that, we are at time. So thank you so much to our presenters, Ben and Verity, and thank you all for joining us today. And we will be following up once again with the recording and some additional information about upcoming webinars. So thank you, and we hope to see you again soon. Take care. Bye.
Thanks for having me.